I'm Dr. Michael DeTola.
And I'm Megan Strong.
On today's Case of the Week, I take a closer look at aesthetic partial clasps.
And I'll show you a recent NBA injury that gives you just another reason to get your kids some mouth guards.
And did Megan try to shave her legs with a Bard Parker or what? That and more on today's Chairside Live. Episode 47 of Chairside Live. Megan, you and I had a chance to hang out at the Chairside Live booth at the CDA meeting this last weekend. Were you as impressed as I was at how handsome the male dentists who watched CSL are?
Simply charming.
They were great, weren't they?
Right.
Came up, got our little trading cards, had an opportunity to say hi to some and sign some autographs.
Yeah, and it was fun. They asked me about, some of the viewers asked me about my mountain biking injuries and how they were progressing and healing, because if you've watched previous episodes, particularly the most recent ones, I have talked about my injuries that I've sustained from mountain biking, and I'm happy to report that they are doing better, but I continue to add new ones to my list day by day. So
you just don't learn, do you?
Apparently not.
I think we should put you in one of those sumo wrestling outfits that you can rent for parties, you know, where you've got the 4 inches of simulated fat, you know, around all your body parts.
That, or just simply wrap me in bubble tape.
Well, then you can, either way. So as long as you fall, you just kind of roll down the hill instead of scraping. All right, well, I hope you heal quickly and stay off it this weekend. Well, while walking through the partial denture department the other day, I noticed many racks of cases sitting against the wall, waiting for doctors to call back so we could go over some material options with them. So on today's Case of the Week, I want to take a look at some aesthetic clasping options and the difference between some materials we use on the partial. So hopefully that'll make it a little easier for you to choose a material. In fact, let's go ahead and take a look at that now. As I mentioned, I was walking through the partial denture department the other day, and I noticed a lot of carts over by the call center where doctors had to be called back. And, you know, we know doctors aren't happy about the delay in a case. It could take an extra week while we play phone tag back and forth. So I wanted to go over the same case and look at it 3 different ways. This happens to be, you can see it's a cast metal base, and we have Valplast. I just marked a little valve there so we can keep in mind which one that is. That's Valplast. Here's that same case being seen with metal and with acrylic. And the same case with the material that we looked at a few weeks ago, something called Duraflex. And it has some nice benefits to it as well. So we're going to look at these different materials just to give you kind of an idea on an identical case how we might be able to do these a little differently. And so we'll refer to these as vinyls when we talk about like the Duraflex and the Valplast for that matter. And the neat thing about vinyls is that they can flex well into an undercut on a tooth. And that makes it a pretty good aesthetic answer to retention, because we can now take, you can see how these clasps come and engage the undercuts on these teeth and do it in such a way that it's not going to be readily apparent to anybody looking into the patient's mouth while the patient's talking, you know, typically on these lower arches. As the patient gets older and the lip starts to sag, we lose a little bit of lip support, and you can start to see more of that. So it's a really nice way to be able to engage some undercuts with either the Valplast or the Duraflex, but they can only flex so far. There is a limit here, and the ideal undercut is probably about 2 to 3/10 of a millimeter, is about as far as we can go. If it locks in any more than that, it's going to be difficult. And if it does have a severe undercut, the clasp is going to end up covering much of the tooth. And so many times we'll make a recommendation to a doctor, or you could do it on your own, to consider some line angle modification so we can place the clasp properly without having to cover the whole tooth. And we definitely receive cases as well where the tooth has no undercut. And so if the tooth is, you know, not very bell-shaped, if it doesn't get, you know, skinny around the cervical third, and there are certainly teeth that are shaped that way, you can actually kind of create your own rest on your own, not rest I should say, but your own height of contour, I guess would be a better way to say that. So after delivery of the partial, you can still have it made and have an aesthetic clasp like this made, and then you can place composite above that. You can mark it with a little flowable, you can just pack some on yourself, or you can mark that area on the tooth with a little skin marker or something, and then take the partial off and then build a little composite and just bond it into place, just occlusal to where that clasp is. And yeah, it takes a little bit of skill to kind of create a height of contour on your own, but as you go in with discs and polish it off, first the time you try it back on, partial won't snap into place over that little bulge there. But as you go in with discs and kind of bring it back a little bit and bring it back and finally get it in, you've got something that's going to be there forever. When it's bonded, when that composite resin is bonded to enamel, even with this vinyl clasp going back and forth over it a couple times a day, nothing is going to move in the case of that composite being bonded to the enamel. It won't come off, in other words. Aesthetically, if we look at these two, like the Duraflex and the Valplast, or even if we bring in the acrylic as well, the acrylic, we're all familiar with that looks like. That is the typical standard gingival acrylic, and it's pink, obviously, so it comes closer to matching gum tissue than obviously the teeth or the clasps do. But you and I both know that when we put that in the patient's mouth, it really doesn't blend with the gingiva all that well. And that's one of the neat things about the vinyls with the Duraflex and the Valplast. You can see it's more translucent, especially the Duraflex. Look how you can see through the clasp. You can see some of the yellow underneath there. And so it's kind of like putting a translucent Empress veneer on a tooth stump that's a desirable color. And part of the nice part is with it being translucent, the light will go in and light up everything. And the same thing happens here. The more translucent this is, the more the patient's natural tooth shade comes through. And we do have a couple different colors in the Duraflex, and I realize it's a little difficult since there isn't a shade guide for that, how to know to ask for the dark or the light. So I typically will just send a picture of the patient's gingiva in when doing either a Duraflex or a Valplast partial to give them a better idea of what we're trying to match. We can't, hit it perfectly, but the more translucent it is, the better it's going to look. Now, for example, if we look at this acrylic partial, since we have acrylic here, we can't make the clasps out of acrylic like we were able to do on the Valplast and the Duraflex, where it's okay to carry that clasp around there. And so on something like this, we've had to go and hide the clasps. And the way we do this aesthetic clasp is by actually engaging the undercut on the distal side of these cuspids. If I can get this little guy off of here. And you'll see now that we have the clasp right along here. So it is going to engage on the distal of that cuspid. And that can work if, in fact, we have, that undercut on the tooth itself. Or we can create that undercut. Or perhaps this tooth needs a crown. And then certainly our combination department will build that undercut into the crown so that the partial the clasp will fit right into that, and we're able to do it. So even though we have that clasp there that you see, when we seat this back down onto the model, you'll notice that it is an aesthetic clasp because it's not visible from the front. If you turn it way over to the side, of course, you can see that, but the cheek is always over there, and so that's not going to be a big deal. Now, the one warning about this type of clasp, anytime you're engaging a distal undercut like this, it's really only going to work well on a tooth-borne partial like this one. That type of design, engaging the distal of a cuspid, for example, is not going to work on a free end partial. We need to have this vertical stop here for this type of retention to work. If we're biting down and this tooth is missing and we're biting down, this is simply going to rotate back if we don't have that stop. So there are limitations to when we can do those aesthetic metal clasps. So we want to make sure that it's not a free end case because it's not going to work very well there. So it is, aesthetic clasping, and we get a nice intimate fit here with metal that we probably couldn't get with any other material there on that apron. I mean, it really gives a nice fit as it works against the lingual of those teeth. And of course, the other nice part about this being tooth-borne and having this rest here is that it's not tissue-borne. It's not going to impinge on the tissue as the patient bites down and dig into that tissue. And here's another model that I grabbed while I was over there. This has been sent in from a dentist to have a lower partial made. You can see a bilateral free end, and you can see that the technician has already marked with the surveyor to show where the height of contour is. And so this is a good example of a case where whether it be a Valplast clasp such as that one or a Duraflex clasp such as this one, it would have to cover the entire tooth in order to be able to kind of engage that undercut because it's not as strong as a metal clasp would be. So when we see something like this where the height of contour is marked that high up on the tooth, this is really a good example of where an I-bar would be more appropriate. This is one of the times where, with an I-bar, we're going to be able to get some good retention down here without having to cover the whole tooth, because as aesthetic as these clasps might look on these two examples, if you take that and cover the tooth all the way up to here, that pink tooth is not going to be very aesthetic, and you're probably better off with an I-bar that's going to end, right about there. So anytime you've got that height of contour and it's so high up on the tooth, as you can see there, that's when we start looking for an I-bar itself. And this is a case, just in terms of one other thing, where if the dentist had prepped, let's say, a cingulum rest here and a cingulum rest here, all of a sudden we could have done the metal apron like this with a couple of rests, and we have a much better chance of when the patient functioned on this denture that it wasn't digging in to the tissue and just driving them crazy and knocking the gingiva down next to the cuspids as well. This is a really good area. Anytime we have teeth left, we're going to want to rely on them for a stop. But of course, if we have a molar here, it's very easy to do an occlusal stop. And we have this whole surface, this whole flat surface like we have on this bicuspid. But because of the slant on the lingual surfaces of these anterior teeth, we're going to need to go in and prep a little rest prep here and here, and then we're going to have a frame that's not going to want to overseat. And as always, our partial denture department and our combo department is more than happy to help you design a denture like this if you want to send a study model in prior to taking the final impression. And they'll send you back a little roadmap showing you where they want you to, what kind of rest they want you to do and where they want you to do it, or if they want you to come in here and reshape this or add some composite to a tooth, to the facial of a tooth, so you can engage the undercut with an aesthetic vinyl clasp on one of those cases. So we've got hundreds of years of knowledge in our partial denture department, and I know that I forgot the little that I learned just a year or two after dental school, because I didn't do that many partials, and I never knew that much to begin with, come to think of it. So take advantage of that resource and use our partial denture department to help you design a successful partial denture with the right guide planes and with the right line angle modifications and rest preps.
Now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. Okazaki in Hawaii, and he writes, "Dear Dr. Mike, I was noticing Glidewell has a new product, Obsidian. How does it differ from Emax Press besides the dye and disilicate? What about its physical properties? Is it CAD-CAM only? One problem I have encountered with Emax Press is the show-through from the stump and a graying of the final shade, even with adequate reduction. Personally, I believe the marginal fit with Press is better than CAD-CAM. It is also 11% stronger. Thanks again for all of your knowledge. You make a tremendous positive impact on our profession. Aloha."
Wow, aloha and mahalo, Todd. You can tell I've been to Hawaii before. Actually, Todd, I will be there in January 2014 at the Hawaii Dental Association meeting, so I'm looking forward to coming over there. And you asked about, the new product, Obsidian, and said what's the difference between the dye and disilicate. They really are, kind of in the same family, cousins, if you will, and they have very similar physical properties. I think the only physical property that really would make a difference between the two is the coefficient of thermal expansion. And so because they're different, the Obsidian material can actually be pressed onto metal. So if you think about it, even though we're seeing a real reduction in terms of the number of PFMs being prescribed, part of the reason is we've got that weak veneering ceramic on the outside of a PFM. Now, what if we could take something that was 3 times as strong, like a lithium silicate material, and fuse that to metal? Now all of a sudden we might have a next generation PFM that has something very strong and sturdy on the top of it. So it's hard to say whether or not that's going to bring back the segment of PFMs, or if it's going to dip and go back up again when we have a higher strength one available. So we'll have to wait and see. So that's really the only difference between the physical properties. I typically explain it to dentists and say, it's kind of like choosing between Pepsi and Coke. You might like one, somebody else might like another one. So it really almost doesn't matter, although there's certainly a lot more clinical studies that have been done on Emax, and now some clinical studies are going to start up on Obsidian as well. You mentioned the show-through on the press material. Emax, for example, the one you mentioned, comes in a variety of different translucencies, and so that can be part of the issue. I know for a fact that I've done some Emax CAD LT, the low translucency, material. Use that for crowns on, say, 7, 8, 9, and 10, where we actually had metal posts and cores, and those didn't show through at all. So I know that the LT material, if reduced enough, like 1.5 millimeters on the axial surface, can definitely block out almost anything underneath it. But that's one of the reasons why I might go to a Bruxer solid zirconia crown in the anterior, is if I have something like a tetracycline stain on a tooth that I think is going to show through anything else that I might place on top of it. You said that you feel like the press has better margins than the mill, and I would tend to agree with you on that. We know that pressed materials, whether it be lithium disilicates or lithium silicates or even just ceramics, pressing onto a margin, we get some very nice fits there. And with the milling itself, part of getting a good margin when you mill is making sure that you've reduced enough. For example, we see dentists who prepare a feather edge or just slightly deeper than a feather edge for an Emax crown and send it to here at the lab, and we know that when we go to mill that is just too thin for a material like Emax or Obsidian, and there could be chipping and you have to fix it by hand afterwards. Whereas even if you did that thinner margin with the press, you'd probably be able to press it even if it ended up breaking intraorally because there wasn't enough reduction. So I would tend to agree with you that kind of just in general, press margins might fit better than milled margins. So thanks a lot, Todd. You asked a lot with those questions. And again, that's a material for me that's kind of in that sweet spot. We've got our weaker PFM feldspathic porcelains and porcelains like Empress here. We got Bruxer way up here that's really strong, but you sacrifice some aesthetics. And then right here in the middle, that sweet spot, that 360 to 400 megapascals of flexural strength. We've got the IPS Emax and now the Obsidian as well. And it really takes advantages of both those properties. We got really nice aesthetics and we got high strength. We don't have the highest strength, but we've got aesthetics that as of today still look better than solid zirconia restorations. Remains to be seen if that will change. So thank you very much for all those questions. Megan, he wrote all the way from Hawaii. Certainly this warrants more of a gift than somebody who just writes from, say, Ohio.
Sure. Hey, don't hate on the Ohioans.
I'm not.
Here you go. Look at this.
Wow, that looks a lot like the gift that somebody in Ohio would have received, or Tennessee for that
matter.
But
here's the caveat in this one. I think that we should personally hand deliver this photograph to Dr. Todd in Hawaii.
Wow. Well, like I said, I'll be out there in January 2014. I don't know if Todd wants to wait that long. He may have cleared a spot on his wall already. Mm-hmm. But let me sweeten the deal since you asked about lithium disilicate materials. This is the Bruxer burr kit. And you say, wait a minute, I did not ask a Bruxer question. I know you didn't, Todd. But actually, as it turns out, the zirconia optimized burrs that you'll find on this burr kit or any of the burr kits for zirconia out there also work very well on lithium disilicate and lithium silicate materials as well. So you'll notice these are fine grit diamonds for these high strength crowns. Little counterintuitive. When I went to cut my first ones off, I went for a coarse burr. Doesn't work very well at all. So even though this is technically a Bruxer adjustment and polishing kit, it'll work very well on lithium disilicate or lithium silicate as well. So we'll toss that in with the picture and send it on out to Todd.
Sounds good.
Very good. Got any news for us?
Yes. Researchers have found evidence of periodontitis, tooth decay, and accident-related dental damage in a mummy named Otzi that dates back to 3300 BC. The findings give insight into the dietary patterns of the Neolithic Iceman and on the evolution of oral pathologies. The mummy was discovered 20 years ago, and researchers say he displays a rather large number of oral diseases and dental problems that are still widespread today. The Iceman probably suffered tooth decay because of his diet, which would have included more starchy foods due to the rise of agriculture during that time. The study authors examined the mummy's teeth using computed tomography and concluded that the loss of periodontium has always been a very common disease throughout history.
Yeah, so that's actually, in a sense, because it goes back so far, it's a little more reassuring that we see periodontal disease on so many people today and know that it's been around since the beginning of time, because we like to blame people for not brushing enough and flossing enough and blame it on a modern diet and all kinds of things. But this guy they found, this Otzi Osborne or whatever his name was, if it's been around that long, and predates everything, and people are still getting it now with the toothbrush and floss, you almost wonder, how much good is the toothbrush and floss doing,
Right.
or did everybody have it back then, or was it just absolutely rampant?
Definitely. And I think that it kind of makes me feel, I've never had, so I've had one quasi cavity where they said, okay, it's maybe going to be a cavity, so we're going to fill it. But I was so proud before that time of, okay, I've never had a cavity. And then once that happened, I was like, oh, shoot, it kind of just took me off my pedestal. But I feel a little bit better about it now, knowing that my ancestors before years and years and years ago had it as well.
And if you look at the pictures here, like on this figure, you can see some of the wear that they found on his teeth. And so this is actually what his upper arch looked like. And if you saw, we do see patients who walk in kind of like that today, but they've been really, grinding their teeth because so much of the food we eat is soft. When you look at this, you'd either have to imagine that they used to eat a much rougher diet than we currently do, or it was just very stressful being, chased by, lions and tigers and things back in the old days of cave dwelling. But either way, you look at that wear, and this guy, Otzi, was a perfect candidate for Bruxer.
Nice.
And unfortunately, it came around a little late for him. You can see the bone loss when you look at this second picture over there. That's not the worst bone loss on the lower jaw along here that we've ever seen. I have patients like this now who have all the benefits of brushing and flossing and fluoride and all that stuff, and that's what seems so odd to me. But if you look at his upper arch, these teeth are about to fall out. These are, they're just, waggling back and forth, and he could probably reach in and take those out himself. But pretty interesting that they had an opportunity to go back, and they're able to do these kinds of 3D reconstructions so we can see what our forefathers had.
Yes.
Anything else?
Yes. If you're a basketball fan, you may have seen the tooth-jarring accident in the recent Brooklyn Nets game against the Charlotte Bobcats. Reggie Evans went up against an opponent in a battle for the ball when an inadvertent headbutt knocked out one of his teeth. He kept playing until the blood forced a timeout to be called, and he placed the tooth on the table in front of the broadcasters, much to their disgust.
Yeah, that was brutal. He actually hit his head against his mouth against the back of somebody else's head, and he's running down the court, and then after he inbounds the ball, he walks over and gets a towel and actually pulls it out himself, much like Otzi could have done on those two molars that he had. And then, just sets it down right down in front of those guys, and they're a little grossed out, and there's blood everywhere, and it would have to be shocking to sit and see that happen. And it reminds me that we make here at the laboratory those play-safe mouth guards that kids can wear. And I remember doing research for an article that I wrote years ago on a sports dentistry article on mouth guards like that. And it was surprising to me how basketball was the #1 sport to lose teeth in, between inadvertent headbutts like that and elbows being thrown
I would
on
have guessed
purpose.
ice hockey.
Ice hockey was definitely up there. There's just not as many people playing it, because Canada's got a smaller population than we do. They've added shields for the pros, and the youth, like my son, who's been playing for 8 years now, they have full face masks. So it's not like the old days where you could actually easily get a puck or a stick in the face. You can in the NHL, but in none of the youth leagues. They've got full facial masks, as do the players more or less in the NFL, so you don't see that many teeth knocked out there. So basketball is the #1 sport for this to happen, and so if your kids do play basketball, whether it's in high school or a recreational league, not a bad idea for them to have one of those play-safe mouth guards to keep it in place, so that one day your son does not run up and set his tooth down in front of the scorer's table, hoping that they will play Tooth Fairy and reward him with some money. Thank you, Megan, for that. That about wraps it up for this week's edition of Chairside Live. On behalf of myself, Megan, and everybody else here at the lab, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time. Thank you for that.
Is that funny?
Yeah, it is. I'm sorry. Thank you for that, Dr. D. Now let's go to a segment. I said segment weird. Try that again. Sorry. Thank you for that, Dr. D.
That's what I do.
That's what I do. Thank you. Sorry. Oh, God. Thank you for that, Dr. D.
Anytime.